Ladies and gentlemen, thank you for attending. I am working in Belgium as a gynecologist interested in infectious diseases, and this is how I come to share my experience with COVID-19 on women with you. I also thank my daughter, who is also a gynecologist, and helped me preparing part of the lecture. I'm a director of Femicare, which is a research company since 25 years now, taking care of clinical research for women with infections and other items, also vaccinations. Work in a private hospital in Tienen, and I'm a professor at the University of Antwerp in Belgium. Finally, I'm the president of the International Society for Infectious Diseases in Obstetrics and Gynecology. It's called IZDoc, and you're always welcome to join us. We have our next meeting in Budapest, the 14th to 18th October. So if you want to have a real conference, please come and join. We are talking about a serious virus. It struck us almost 2 years ago, coming from Wuhan in China, and then swept all over Europe, filling our hospitals, killing many people. Still now we are very worried about this disease. When we talk about women, we would like to see if there is a difference between gender. Is there a difference between males and females? In general, what about pregnancy? Is there specific risks in pregnancy? Is there a risk of vertical transmission in utero, so the baby gets born infected? Can we do breastfeeding? Is it safe? What about getting pregnant? Is there an impact on fertility? There's lots of questions of women about fertility. What about the vaccine? Can we use it? Is it eligible for pregnant ladies? And what is the impact of all this on women's mental health? Here you see a lecture, a picture from the gender differences that we have in large series from Chinese men and women experiencing COVID. First of all, what is clear is that there is more females affected by mild, moderate, and severe disease of COVID. If it gets to the serious life-threatening disease, it looks like much more males are affected. And this is reflected in the mortality data. As you can see here, according to age, there is a much higher trend of dying in elderly people than in younger people. That's an open door that everybody knows. But what is less known is that males die of COVID much more easily than females. There is a higher survival of females having COVID. What about pregnancy? Pregnancy has a lower cellular immunity, preserved humoral immunity. Concerning the incidence of COVID in pregnancy, it's very similar to non-pregnant women, so there is no difference. And also, at first view, the symptoms are rather similar inside pregnancy or outside pregnancy. Here you see that in a meta-analysis, there is no difference in the symptoms in general. However, if you look at specific symptoms such as fever, you see that pregnant women have much higher fever and much more fever than non-pregnant women. And also dyspnea or myalgia better is much more prevalent in pregnant women than in outside pregnancy. Concerning diagnostics, much is similar to pregnant women and non-pregnant women. The leukocytosis is a difficult marker because it's also very often physiologically increased in pregnancy. And the increased liver enzymes and thrombocytopenia makes us worry that we are missing preeclampsia or HELLP syndrome. So this also makes differential diagnosis very difficult. Nowadays, we can do lung X-rays and CT of the thorax in pregnant women, which will help us to make the diagnosis of COVID or severe COVID in these women. The clinical the clinical picture of COVID in pregnancy is now known to be much more severe than outside pregnancy. As you can see from this review, this meta-analysis, there is a 60% higher chance to come on intensive care if you're pregnant. There is a 90% increased risk of having invasive ventilation if you are admitted. And if you have increased risk factors such as a high body mass, hypertension, or pre-existing diabetes, your odds ratios will even increase more if you are pregnant. So there is a double risk, not only increased risk factors that are known, but also pregnancy increases these risks even more. In the CDC, there was a report of 500 hospitalized patients, of which 6% were pregnant. They published age and ethnicity adjusted risk factors for SARS-CoV-2 infections, which showed us that there is a 200% increased risk of having an ICU admission if you are pregnant. There is a 190% increased risk of having mechanical respiration and a 140% increased risk of having a heart lung machine necessary. The mortality is 70% higher if you're pregnant than non-pregnant. So pregnancy increases mortality risks with 70% if you get COVID. So why is this so devastating in pregnancy? Well, first of all, we know there is a higher increased need of oxygen and a higher cardiac output in pregnancy, which makes it more likely that the disease gets more severe if it attacks your lungs. Also, the lung capacity is already lower due to diaphragm pressure of the baby, certainly in pregnancies with the third trimester evolution. We already discussed the decreased cell immunity and the increased risk of thromboembolism in pregnancy. All of these made us consider every pregnant woman to be at increased risk if you develop COVID in pregnancy. So we need extensive preventive measures like hand hygiene with alcohol and so on. Also, if you are pregnant and work in a high-risk area, like in labor and delivery wards, respiratory wards, intensive care wards, and so on in hospitals, you need to be considered to be transferred to low-risk exposure settings. Of course, now with progressive vaccination, these guidelines could be adjusted, but this is what we published in the ICDO guidelines recently. What is the risks for pregnancy now? Well, lots has been learned out of these prospective cohort of pregnant women in the UK, where they saw that 26% of women delivered preterm, which is much higher than the background preterm delivery rate of 6%, 10% of which were before 32 weeks. Also, they found a high increased number of C-sections. All one-third were for maternal compromise reasons, and one-fourth were for fetal compromise reasons. So this also needs to be taken into account. If we look at the pooled proportion of preterm birth in meta-analysis, again, we see a very tremendous increased risk of preterm birth, odds ratio of 0.22, which means a 5-fold increased risk of preterm birth. If we split this in spontaneous preterm birth or medically indicated preterm birth, both are tremendously increased, as you can see. And the spontaneous preterm birth even more than the medically indicated. This obviously results in an increased risk of C-section. As you can see, a 50% increased risk of C-section, double as much as normal. The outcomes of the neonate have to do with placental malfunction. There is a maternal vascular malperfusion in COVID patients that is 3 times as high as in control patients. Also, the presence of intravenous thrombo-embolic phenomena in the placenta is at least 5 times higher in COVID-19 patients and 19 patients than in controls. So this could be the reason why there is much more perinatal deaths. Stillbirths are 3 times more frequent in COVID patients than they are in controlled pregnancies. And this is also confirmed in systematic reviews. Obviously, living babies, when they are born much more preterm, they end up much more likely in neonatal wards. 25% of births end up in neonatal admission of baby. So is there any risk of vertical transmission? We do know that SARS-CoV-2 viruses are RNA viruses with a single strain DNA, just like Zika virus and Rubella and Ebola. So they are in this group, and so this makes us worry that it could go over the placenta and is teratogenic. However, viremia in COVID-19 patients is very seldom, less than 1%, and it is very transient if it happens, so it doesn't stay long. Also, the SARS-CoV-2, in order to enter a cell, is dependent of the angiotensin converting enzyme 2 receptor, which is not at all or very minimally expressed in placental tissue. Still, there is some case studies published of newborns that seemingly have a positive PCR in the umbilical cord or the neonatal blood early on collected from these babies. And some have nasal swabs that are positive. These nasal swabs are positive in almost 3% of kids born to COVID-positive women when these are taken within 24 hours after birth. Also, PCR is positive in around 3% of cord blood samples, and likewise, as can be said for immunoglobulin M, which is probably made by the neonate itself. So in a meta-analysis, many studies already showing this, we again come to the number of 3% of positive neonatal nasopharyngeal swabs of SARS-CoV-2 kids born to women with COVID. Is all of these 3% acquired antenatally? Most likely not at all. We think about 12% are probably or confirmed congenital cases. Another 18% are acquired during the moment of birth, and the remaining 70% are postpartum acquired by probably hands or saliva transmission. So what do? We have lots of drugs being tested for SARS-CoV infections. Remdesivir is the most studied one, but it still has controversial benefits and it cannot be used in pregnancies. Antibodies and plasma also quite controversial, not to be used in pregnancy, such as the interleukin-6 pathway inhibitors. They don't seem to have any benefit. Drinking chloroquine, we leave it to the former president of the United States. I think this has no benefit and should not be done. The only thing that does seem to have a benefit, reducing maternal mortality after 1 month, is dexamethasone, not only for lung maturity of the baby, but also for saving mothers. We can have a clear benefit of dexamethasone use in COVID-positive women. The main issue is then the VTE. Here we see the data. VTE after 1 week, 2 weeks, or 3 weeks hospitalization is tremendously increased over time, as well in hospitalized patients in light orange bars, as in intensive care admitted patients in the dark bars. So we have to be careful with these VTEs. It led to international guidelines of thromboseprofylaxis in pregnancy, where we need to treat with low molecular weight heparin during the full stay in all hospitalized patients, and in postpartum patients, at least for 10 days, we have to give high dose of these heparins. And if there is an increased risk factor for severe infection, even during 6 weeks. This led us to another discussion, what to do with vaccines in pregnancy. I was in the committee in Belgium to discuss about this, and showed the members of the group these slides, where you can see that the recognized risk factors for priority vaccination were metastatic tumors, myocardial infarction, cardiovascular disease, dementia, diabetes, chronic pulmonary disease, etc. But as you can see, the risk factors of these, mortality risk factors of these diseases were 11 to 57% higher than the community, which led the expert group to see these as accepted priority groups for vaccination. However, if you look at pregnancy reviews, you could see that also pregnancy should be considered as a high-risk group for vaccination. And this comes from the risks of, compared to other risk factors, of 70% of dying during pregnancy, as opposed to an increased risk of 11 to 50% of dying in the other risk groups. So without any doubt, COVID infection in pregnancy leads to an increased risk of being admitted to ICUs, but also to die. Therefore, because of this increased risk, and additionally, because of the increased risk of being born preterm for the baby, we severely consider all pregnant women as a high risk to be prioritized for vaccination with COVID vaccines. This was issued in the consensus guidelines for COVID vaccination, as was published now in the Journal of Clinical Medicine. Is there any risk of teratogenicity of these types of vaccines? The mRNA vaccines have been studied at length, and there is no possible genetic change in a person's DNA, so risks of teratogenicity is very low. And also for the viral vector-based vaccines, there is both in animal and human studies, very low or negligent risks of having teratogenic effects. So this is safe vaccines. The published evidence of the VSafe registry also shows in terms of stillbirths and preterm births and spontaneous abortion lower or similar rates than in the published evidence in the non-vaccinated population. So there is no signal that we should be afraid of vaccination in pregnancy. Also, if you compare the mRNA vaccines symptoms after the vaccination within or without pregnancy, there you can see there is no difference in symptomatology in pregnant patients or non-pregnant patients being vaccinated. The safety concerns two issues. You have the post-vaccination anaphylaxis, and we know this is a female issue. 90% of these anaphylactic cases were females after getting vaccines. What is very important is that most of these women were known to be allergic or had allergic reactions in the past, or even anaphylaxis. So we have to be very careful with the previous history of allergies, and these women should maybe wait being vaccinated until after pregnancy. Also, the thrombo-embolic complications that we've seen, most of them like myocardial infarction, pulmonary embolism, and cerebrovascular accidents, were seen in elderly women above 70. The cerebral venous sinus thrombosis are very seldom, and they are seen in younger women. The deep venous thrombosis and the pulmonary embolism, as you can see, are very low in the observed cases that have had the vaccines, and were much lower in rates than you would expect from the normal population. And the cerebral venous sinus thrombosis cases were not increased in higher incidences than in the non-vaccinated general population. So therefore, there is no indication of refusing vaccines to women, and certainly not to pregnant women. Concerning fertility, there is many issues. Women are having very many worries about pregnancy. Here we show you our data of male infertility and male sperm quality after COVID. We screened 124 males after COVID, proven COVID infection. Eligible for sperm testing were 120. Then there were 2 after vasectomy. So for sperm quality testing, there was another 180 left. So the infectiosity of sperm was tested in 120 Belgian males, 18 to 65 years of age. They were tested 1 week to 6 months post-proven COVID infection. They were either recently infected within 1 month and then tested, or intermediate 1 to 2 months, or after a longer period of time. So they were not selected for infertility diagnostic. They were just males having had COVID. We used a validated test where we added COVID virus particles to sperm to test and validate these tests. And when we used this in these 120 sperm samples, none of them was infectious. No PCR was positive. However, when it came to the sperm abnormalities, the quality of sperm, we could see here you have in the light bars the early tested cases. In the orange bars in the middle, we have the ones that were tested between 1 and 2 months after COVID. And in the brown bars, we have the ones that were tested after 3 months after COVID. You could see here that the concentration, the motility of the progressive sperm, the total motility, and in category 4, it means the DNA damage, was all very much abnormal in the first month tested cases. So the ones that were tested early after COVID had a severe impairment of their sperm quality, not only for motility, but also for quality. However, after 1 month, it started to decrease, and after 3 months, we almost get to normal levels of So people from the female side who want to become pregnant, we know that the ESHRE guidelines say that you should wait maybe 2 months before the antibodies levels are no longer fluctuating and the antibodies are formed. So then you should have no longer any effects on the oocytes and the sperm for artificial inseminations and so on. But there is not much evidence for this. It looks like these women that want to become pregnancy definitely can continue their treatment for infertility and get their vaccination at the same time. Also, breastfeeding women after delivery should, without any doubt, get the vaccine. The antibodies will be passed over by breast milk. There is enough evidence for that. So there will be a natural protection against neonatal infections, according to Italian studies. So breastfeeding women should be encouraged to be vaccinated. Finally, women with vulvovaginitis in COVID times, how does that go? We don't have any vulvovaginal genital symptoms due to COVID, but does it influence the prevalence or the incidence of vulvovaginitis? We don't think so, although there is less travel, less interaction, and maybe also less sex. We don't have the idea that it has a major influence. The doctor's visits are much more limited due to new COVID rules. So the urgent problems are still seen, like a herpes or an acute candida infection. But the ones on a long-term maintenance regimen, they would often not show up for control visits. So what we normally would do, we would have phone visits or internet visits. And as we have lack of control examinations, we would keep them on their prophylactic regimens as they were doing, and we would not adjust it too easily. What we also see is much more self-medication, over-the-counter medication by the pharmacist. So we have to deal with this, and we are not always sure that people are treating the conditions well and that they have proper treatment for the proper conditions they may have. We miss women a little bit on pregnancy, early vaginal microflora visits. This is often omitted. Also, we miss office microscopy, which is sometimes a problem for mixed infections pickup and for treating the right conditions, by the way. But on the other hand, what we learned from COVID is that a lot is possible. We adjust regimens by phone interviews and email pictures. We are solving problems by email pictures, which is not ideal, but it helps in some cases. Some self-limiting conditions also are no longer seen at the consultation. And then there is definitely an increase in self-testing, self-collection swabs for labs that are sent over by an envelope, by post, or enzymatic or molecular self-tests that give you results immediately at home. Even now upcoming is an artificial intelligence microscopy coming so that you can make a swab yourself, put it in a machine, and the machine does the microscopy for you. Of course, what an impact finally does this have on women? We are very sad to read on websites of the United Nations that COVID really impacts women and girls. There is 240 million women being physically and sexually abused. Since the pandemic, there is an increase in this by their male partners, and also domestic violence has been reported 30 to 32% more than before the lockdown. So this leads to lots of stress and depression in women, especially women who are pregnant and during postpartum. They are very vulnerable for this. And here also you see that women's health is severely affected, not only by gender issues, but also by fertility issues, pregnancy issues, and postpartum issues that keep these women busy and makes them much more suffering from anxiety and depression. So I thank you for the attention. I will definitely try to be online to answer all of your questions if you might have.